Hello and welcome to a Health Podyssey. I'm your host, Alan Weil. Percutaneous coronary interventions, or PCIs, are critical medical procedures performed when a person has a blockage in a coronary artery. More than 1 million PCIs are performed in the United States each year. Now, given the critical role these procedures play, equitable access to them is an integral part of an equitable healthcare system. So, are PCI services available in the U.S. on an equitable basis? That is the question we'll explore in today's episode of A Health Podyssey. I'm here with Renee, professor of emergency medicine at the University of California, San Francisco. Dr. Hsia and colleagues published a paper in the July 2024 issue of Health Affairs examining structural inequities in the opening of PCI centers at hospitals between 2000 and 2020. They found that hospitals serving racially segregated communities with larger Black and Hispanic populations, were less likely to adopt these services than other communities. We'll discuss these findings and more in today's episode. Dr. Hsia, welcome to the program.
Thanks so much for having me, Alan.
Well, thank you for being here. So let's start with the non-clinicians like me. I've heard of a PCI. I think I even knew what it stood for, but I don't really know what they are, who gets them, why they need them, how important they are. If you could just orient us a little bit on the clinical side of this before we talk about the policy side.
Absolutely. So PCI stands for percutaneous coronary intervention. It's basically what happens when you have a heart attack, a specific type of heart attack, when you have a blocked artery in your heart and you need to open it up. So what PCI does, percutaneous coronary intervention, percutaneous meaning they go through the skin. They actually put in a needle into usually your groin, into a big vein in your groin, and it snakes all the way up to your heart. And what that does is you can see where the blockages are after you put in some dye. And when you see where the blockage or blockages are, you can actually put a stent or balloon and dilate that blocked blood vessel. And that opens it up and restores blood flow to the heart. It's a life-saving procedure for people with certain types of heart attacks. And so in the emergency department where I work, we see patients come in with chest pain. And if they have this specific type of heart attack, they're called ST elevation myocardial infarction or other types of myocardial infarction. We know that you need to be rushed to what we call the cardiac catheterization laboratory so you can get this PCI. Not all hospitals have a cardiac catheterization lab and can do PCI emergently because it's a specialized procedure. And so what we wanted to study in this particular paper that we published was to see whether or not the availability of PCI is equitable in the sense that whether or not hospitals make this choice of making these services available in an equitable way and whether or not this happens differently across different patient populations.
So I appreciate that explanation for a non-clinician, and it reinforces something that is so central to this, which is that timeliness really matters here. I've heard of, time to balloon and things like that. So access isn't a matter of, the inconvenience of going a little farther or waiting a little longer. It actually genuinely could be a matter of life and death.
That's absolutely true. There are some patients who get cardiac catheterization diagnostically, meaning you have chest pain, you go to your doctor's office and say, it's been on and off. I don't have any now, but last month I seem to have it. And those are elective procedures. But what we're talking about in terms of PCI, in terms of a life-saving procedure, is when you have a heart attack and you need it done exactly as you're saying. We say, time is muscle, time is heart. And so we try to get patients in a cardiac cath lab as soon as possible.
So before we talk about access to the services, another dimension of equity is the need for the services. And ideally, in an equitable system, you align access with the need. So can you say a little bit about the equity dimensions of who actually needs the PCI intervention?
That's such a great question because I think a lot of times when we're thinking about provision of healthcare services, we assume that everybody has the same need, but that's not always true. And so in this case, in terms of acute myocardial infarction or heart attacks, we know that traditionally underserved patient populations, they have worse heart attacks. They have delayed presentation times to treatment because of other factors such as whether it's education or historical reasons for not seeking care, and that there's other comorbidities that affect these patient populations so that the burden of disease is actually greater.
So that seems like a critical dimension. Equitable access wouldn't actually mean equal distribution across the population. Equitable access would mean a higher availability among the populations where the need is likely the highest. So with that as a backdrop, you did then look at geographic disparities in access to these services. And you looked at it along a number of dimensions. I wonder if you could just start with sort of the major findings. What dimensions did you look at? And generally, what did you see?
So we looked at geographic disparities, how far you live away from these PCI services. And we looked at a couple of dimensions. So we looked at race, Black versus non-Black, patient populations, ethnicity, Hispanic versus non-Hispanic ethnicities, income, low income versus high income, and rurality, rural versus urban. So we looked at basically the composition, the predominance of these groups within a given category, and the segregation status, meaning was that community segregated or integrated? Because we wanted to identify these historically underserved communities more accurately. And we chose these 4 dimensions. It was based on the National Institutes of Health. They specifically categorized these particular types of groups as traditionally underserved. And so we wanted to look at their access.
And what'd you find?
So we found a couple of things. First, we found that hospitals that serve communities with a high degree of residential segregation and high shares of Black and Hispanic residents had the lowest likelihood of adopting these PCI after we controlled for population and hospital size. Specifically, hospitals that were serving Black and racially segregated communities were 48% less likely to adopt PCI services than those serving non-Black segregated communities, which was our reference community for that. We also found that hospitals serving Hispanic, ethnically segregated communities were 41% less likely to adopt PCI services than those serving the reference group of non-Hispanic, ethnically segregated communities. So that's our first dimension of race and ethnicity. And then when we looked at economic integration, so low income and high income, how often do these, when we look at segregation in this sense, we're looking at economic segregation. So low income and high income mix of how closely they live together. When we talk about segregation, a lot of times people only think of racial segregation, but in this dimension of financial segregation, we're talking about economic integration. So we found that hospitals that were serving economically integrated communities were 1.4 and 1.8 times more likely to accept PCI services than high-income economically segregated communities. And then when we looked at our last dimension of rural hospitals, that's perhaps not surprising to find that rural hospitals were 47% less likely to adopt PCI services than their urban counterparts.
So these are some really striking findings, and I want to map them back to the discussion of equity that we started with. We'll turn to that topic after we take a short break. And we're back. I'm speaking with Dr. Renee Hsia about hospitals opening PCI centers, percutaneous coronary intervention centers. Before the break, we learned about these very sizable differences in the likelihood of adoption of these services along a number of dimensions of geography. So I'd like you to sort of take what sound to me like very strong findings and map it back to this notion of access disparities. We are in the midst of many organizations saying that they're trying to reduce inequities, to create health equity. What do these findings tell you about the progress we're making, at least in this domain, with respect to trying to achieve health equity?
Well, I think it's important to recognize that this is not individual discrimination of who gets services and who doesn't get services. It's often times when people think about discrimination, I think people, may tend to associate it with, one individual choosing not to treat another individual, or a physician specifically denying treatment. But in this case, we're talking about systemic access and systemic discrimination, in the sense that the system does not allow for the patients who need this type of treatment to receive the care in an equitable way, because they just don't have it available. It's geographically not available to them. And we know it's well established, and there's even common sense that if you don't have something near you, you're not going to use it as much. You're not going to have as much ability to go there as somebody else who's next door to it. And so I think, when we look at our results, when we find that hospitals serving communities with a large share of Black and Hispanic residents and a high degree of residential segregation were half as likely to adopt PCI services as hospitals in their reference communities, meaning non-Black and non-Hispanic segregated communities, then we have empirical evidence that there are system failures in our provision of equitable access to life-saving care. And that we also see that, when we look at the flip side, I didn't talk about these results too, but when we looked at the flip side of closures, we found that closures were more likely to occur in Black racially segregated and Hispanic ethnically segregated communities too. These were the same communities that had the lowest likelihood of adopting them in the first place, but yet they have a higher likelihood of closing. And so I think these findings should ring alarm bells, because when we look at outcomes, when we say, this certain patient population, Black patients have a higher mortality, maybe part of the mortality is because we're not getting them the care that they need, because they don't have equitable access to life-saving cardiac services. And so I think that these findings hopefully are sobering, and also make us think about the role that, whether it's regional or state or federal governments play in terms of creating this type of more rational system. I think sometimes many of us think that there may be, some kind of a good big brother kind of telling us where hospitals should be, that somebody kind of makes a decision based on, there's a lot of people here, there's a lot of need here, we should have a hospital here. But people are surprised to learn that's actually not how hospital services are provided at all. Because we have a very market-driven approach to healthcare in the United States, hospitals themselves, most of whom are private, are going to decide whether or not they can keep those services open or not. And there are a multitude of reasons behind those, a lot of them basically based on money, whether or not they're mission-oriented and don't have enough money to keep it open, or whether they're for-profit and are trying to line the pockets of shareholders. We want hospitals to be making decisions about who gets care, but that is the reality. And so I think hopefully these findings provide empirical evidence about the kind of system that we have, so policymakers are armed with the information they need to start thinking about whether or not we want to have more rational allocation of these services by someone, not just the market.
So you've covered a lot of ground here, and I want to sort of start with the overarching point, which is that individual level discrimination is a real thing, but the data you're showing here really are about system design and the differential effects for different people based on how the system functions, not how any individual makes a choice about whether or not or how to treat an individual person. And it makes me think then, when a hospital adopts a strategy of saying we want to provide equitable access to our community, I doubt most of them are thinking, what are the services in our community that are not as available as they need to be for the health of the community. They're thinking more, we treat everyone equally, or we try to help people overcome the barriers they have outside the health system. But this notion of thinking of service lines as an equity function, I don't typically hear hospitals talking about it that way.
And I think that's absolutely right. You hit the nail on the head. There's so many programs that hospitals may throw into equitable access. Let's be welcoming to all patients, regardless of where they come from. And I think that is important. And there is important data showing that we need to, do better in terms of our individual, treatment of patients. There's discrimination on many, many levels. But you're right that this specific aspect that we study in this paper is something that isn't unfortunately addressed by most of the interventions that hospitals pursue, that governments may ask hospitals to pursue, because it's a more fundamental question of service lines. And because there's no regulation, very little regulation in this space. No one says that a hospital has to have a PCI service. No one says that a hospital has to have an emergency department. You can close these service lines at your will. That means that there's a huge gap. And that gap is also a huge area for improvement. But I think we want to first be aware that this is a huge gap. And then we can start thinking about how do we start addressing this.
Now, I hesitate to move away from the harm to communities of not having PCI services available. But you note in the paper there are also risks to having excessive PCI capacity. Can you explain that to me?
So Tom Concannon did a lot of work on this a few decades ago, and he had produced some really great papers on looking at what we call systematic duplication in the growth of PCI availability. So the fact that hospitals have an incentive to try to duplicate services in areas that may have a, quote, good patient-payer mix, meaning that they reimburse well. And so there's good evidence to show that in areas that already have PCI, they have plenty, hospitals start competing for these patients by offering more PCI services. And so there's lots of examples that, you can kind of call out, whether that's where I trained in Harvard for Boston Longwood, you have several hospitals clustered very closely on the same street sometimes, which offer these services. And I'm not saying that there's not a need for them, but there is evidence to show that there is this duplication, and what we would be concerned about is a redundancy. And why does that matter? Because there is a very American idea that more is better. Why not? What's the harm? Well, we know actually, and this is well established in the literature, that hospitals that see more of a certain thing are much better at it. And because doing something like sticking a needle and dye into somebody's heart is not a benign procedure, we want to have people who are experts at that do it. But when you have what essentially is a fixed volume, right? We're not changing the number of people who have heart attacks, hopefully, that is a fixed volume, but that now they're being diffused across more hospitals. Then the practice of those, not just the physicians, but everybody involved. When we work at a hospital, every single person involved. It's the tech who's doing the EKG. It's the nurse who's doing the lines, who's every single part, pharmacy. All of those parts are essential. Then if people get less practice, they're not as good at it. And so we know that when you get procedures and when you get these kind of more complicated procedures at low volume hospitals, your morbidity and your mortality increases, and that there's unnecessary morbidity, unnecessary mortality, because you're simply, spreading them across more facilities. And, just as an example, that's why we don't have a trauma center on every street corner. You don't want your trauma surgeon or the trauma team to just take care of one gunshot wound a year. I mean, ideally, actually, that would be the case if we were in Sweden.
Pick a different example. Yes.
Right. But if you have a gunshot wound, you don't want to be seeing someone who's only seeing somebody once a year. And so in the same way, for cardiac emergencies, for stroke emergencies, neurological emergencies, anything like that, we want to be able to have the volume go to a place that's specialized in that care. And when we have redundant services, that means one of two things. One, either you start getting a procedure at a place where it doesn't have the same volume, or two, that place tries to keep up its volume by potentially doing discretionary procedures, meaning procedures that, we wouldn't have done them before, and they're not necessarily ones that are recommended, but maybe we should do them just in case. And there's societies that have certain recommendations for cardiologists to keep up their numbers, to stay certified, which makes sense. All of these are well-intentioned policies. You don't want your cardiologist to be, doing an intervention if he only does one a year, again. But because they have certain volume requirements, and hospitals have volume requirements, then what's the alternative? The alternative is to perhaps do them on patients where, oh, they had a little chest pain and normally we wouldn't have done it. And the literature says that actually that patient may not benefit. But you know what? Let's just check. Let's just go in and just shoot up some dye and see if there's something that we can fix. And so there are real risks associated with excessive or redundant capacity. And so I think it's just important that, when we think about the US in a place where there's haves and have-nots, sometimes the people who are in the have category tend to think, oh, well, the poor will always be with us, and that's unfortunate, but at least we have what we need. But there are real harms to this inequity. And so I think that's just another really important layer to help people realize that we're all in this together. And that's not just lip service to say.
Well, let's return to your overall findings, which I think can be summarized as really quite substantial disparities that arise from, as you noted, market forces that lead to the choices hospitals make. And those markets are complex. We're not going to dive way deep into them, but it has to do with payer mix. It has to do with competing for clinicians and competing for patients. What you're describing is that the way we allocate these resources in the system we have in this country is one that leads to inequities with potentially very significant health harms. You mentioned the idea of sort of a benevolent big brother. And so I guess as we come to a close, I would ask, what policies come to your mind as you see these inequities that you think might address them or respond to them in part, given the system design that we have?
Well, I think, the more fundamental long-term questions would be how we redesign a system where we pay and deliver care in a way that is aligned with really patient benefit. And that probably is another discussion, but I do think it's important to recognize that there really does need to be fundamental change for us to have more equitable services that benefit everybody, not just those who don't have. But in the present time, barring that, although we hope that would be something that, I think our society would consider, that I think barring that in the present time, I think there are some things that we can do, which would be, one of those would be incentivizing and supporting hospitals in these traditionally underserved communities to open these new cardiac facilities. And that does require additional financial investment from likely governments, because private finance doesn't have motivation to necessarily provide that. And so there's a couple of, programs for the administration currently to support rural hospitals, which I think are important, as well as providing not just the facilities, but also the incentives for healthcare professionals to work there. So just because you have a building doesn't mean that they'll come. It's not quite that Kevin Costner quote. So how do we get physicians to want to work there? And not just physicians, but also nurses and techs. So, whether or not these more programs such as loan repayment, loan forgiveness, professional development opportunities, I think are important. We recognize that, there may be also a role for other government, or whether or not that's state or federal kind of measures. And so there are things that exist like certificate of need, certificate of authority, certificate of public advantage, all of which have had varying degrees of success depending on whether or not these kind of policies can be gamed, who is on the board, all these things. But I do think that there is a role for considering whether or not, maybe they're not perfect. But just because there's government failure does not mean that the market is succeeding. And so I think it's important to recognize that there may be ways that, maybe, certificate of need wasn't perfect when it was implemented and where, X state in what year. But are there ways we can learn from that? And we can tweak that so that it is a way that still fosters, healthy competition, but allows for a more streamlined service provision so that not everybody is becoming certificate of need. Or, maybe if you want to open a service, you are required to have, it has to be outside of a certain boundary. There's ways that we can, things like certificate of need or those things are not just binary things. There's lots of ways to tweak them so that they fit our current circumstance. And then I think just overall, just having, increased government oversight and regulation, it may be necessary to discourage hospitals from opening PCI services in areas where demand has already been met. And so, this starts becoming quite broad, but, whether or not we need to expand powers of the Attorney General to pursue anti-competitive practice. Already the FTC is doing a lot in that as well. And so I think these are encouraging signs to recognize that, if we're going to have a capitalistic healthcare system, then we need to have those other enforcers in place. We can't just kind of leave it and hope things go well, because as we see, actually, things are getting worse.
Well, Dr. Hsia, thank you for explaining this complex topic so nicely and for shining a light on a real system failure here. It's hard to look at these results and conclude anything other than that we're doing something wrong if we care about health and health equity, which I believe most of our listeners do. How to get it right is a harder puzzle, and you've started us down that road, but just having a clear documentation of the inequities, as you call them, the structural inequities associated with the decisions that individual hospitals are making based on the individual circumstances they confront, it gives us something very important to work with to try to figure out how to do this better. So I appreciate the analysis and your clarity, and I thank you for being my guest today on A Health Podyssey.
Thank you so much. I also want to thank my co-author, Dr. Shen, who's done a lot of this. And we really appreciate just being able to be part of health affairs just over this long term and sharing our work and learning as well.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about A Health Podyssey.